Thank you very much, Professor Sejong-won, Professor Hoyeong. Ladies and gentlemen, good morning. It is my great privilege to have an opportunity to be a speaker in this morning session. This is my disclosure information. Let me start with the risk of ischemic stroke in patients with atrial fibrillation. Women, AF, has several characteristics compared with atrial fibrillation in men. The incidence of atrial fibrillation is low, but the prevalence is same in women because women live longer than men, and women have more symptomatic atrial fibrillation and higher risk of stroke. Women favors less invasive intervention, less aggressive antithrombotic therapy, and less likely to be included in large clinical trials. Also, women shows a higher adverse events during rhythm control strategy. Multiple large-scale clinical trial studies have documented that the female atrial fibrillation patients have a high risk of ischemic stroke. Therefore, the female sex is considered 1 point in the CHA2DS2-VASc score. Even in the study with low-risk stroke patient, CHA2DS2-VASc score 0 and 1, female AF patients shows a higher incidence of ischemic stroke than in men. So female sex is a significant risk factor for stroke in patients with atrial fibrillation, even after excluding the potential comorbidities. I would like to explain the ventricular atrial mechanistic linkage to understand the sex difference in AF pathophysiology. In general, we observe a higher atrial remodeling in patients with higher CHA2DS2-VASc score. In these electroanatomical maps, red area suggests low voltage and gray area reflects low voltage scar. And CT image shows a larger left atrium, and electroanatomical map shows a larger low voltage area in patients with higher CHA2DS2-VASc score compared with CHA2DS2-VASc score 0. Ventricular atrial mechanistic linkage means the relationship between LV diastolic function and atrial myopathy. In patients with higher EO prime, left atrial pressure is significantly higher and the left atrial remodeling is significantly progressed. It is because high LA diastolic pressure affects left atrial pressure and remodeling directly during mitral valve opening period in patients with LV diastolic dysfunction. And the electroanatomical mapping, LA electroanatomical remodeling directly affects the left atrial appendage function, and appendage flow velocity was significantly lower, and the EOA prime was significantly higher in AF patient with larger left atrium and lower LA voltage. That might be the reason for the higher risk of stroke in patients with heart failure with preserved ejection fraction, HFpEF. So to exclude the effects of comorbidities, we evaluated the risk of stroke and CHA2DS2-VASc score, which reflects the degree of HFpEF and the LV diastolic function. And in this study, we found the higher stroke risk in AF patients with higher HFpEF score, especially in older age group over 60 years old and higher EOA prime. We also found that the epicardial adipose tissue volume affects atrial myopathy. We measured the post-ablation 1-year LA reverse remodeling, and the patient with poorer reverse remodeling shows the low LA voltage and higher HFpEF score at 1 year and significantly higher ventricular adipose tissue volume, but not atrial adipose tissue volume. Then, how different is this LA remodeling between men and women? Generally, height and extremity lengths are shorter in women than in men. Therefore, central blood pressure is significantly higher in women with same peripheral blood pressure. In other words, women are more vulnerable to hypertension and or pulse pressure amplification, and resulting in left ventricular hypertrophy, diastolic function, and potentially atrial myopathy. Therefore, EOA prime was significantly higher, and LA voltage was significantly lower in women younger than 65 years old than in men, and the LA volume index was significantly higher in women with CHA2DS2-VASc score over 3 than in men. These are typical examples of sex difference in LA remodeling in spite of the same age proximal atrial fibrillation. Women shows significantly higher EOV prime, larger left atrium, and lower LA voltage compared with men. This suggests women are vulnerable to diastolic dysfunction and atrial myopathy. Now let me summarize the recent outcomes of AF catheter ablation. The Cabana trial proved the superiority of mortality and cardiovascular hospitalization of atrial fibrillation catheter ablation group over medical therapy group, and the Castle AF trial shows overall mortality benefit of AF ablation in heart failure with ejection fraction less than 35%, HFrEF group. What are the effects of AF ablation in HFpEF patients? We estimate the degree of LV diastolic function by evaluating the baseline and 1 year HFpEF score. In this cohort, 21% of patients showed a reduced HFpEF score at 1 year, but 17% shows the increased HFpEF score. And AF ablation effectively reduced the HFpEF score in patients with baseline LV diastolic dysfunction and shows the worst 1 year HFpEF score in patients who recurred with sustaining atrial fibrillation. AF ablation also reduced the risk of ischemic stroke to the level of non-AF population compared with medical therapy group alone. Of course, those patients keep continuing the anticoagulation based on guideline. And the AF ablation also improved the 5-year follow-up renal function than in medical therapy group. We also proved the improvement of 1 year cognitive function after AF catheter ablation and the reduced risk of dementia with or without ischemic stroke. Then how different are AF ablation outcomes between women and men? AF catheter ablation procedure related complication risk is significantly higher, women, especially elderly ladies. In this study, we measured the PV antral wall thickness of CT scan and evaluated the sex difference in wall thickness and the risk of complication. We found that the major complication risk and the risk of tamponade were significantly higher in the ladies older than 75 years. And the left and right side PV antral wall thickness were significantly thinner in those old ladies. CONA score is a standard malnutrition score, which differs from body mass index. Among over 3,000 patients who underwent AF ablation, 0.4% of patients had moderate to severe malnutrition, 30% was mild malnutrition, and we found a significantly higher overall and major complication risk in high CONA score group, especially in female patients with malnutrition. The outcome of AF ablation is also worse in women, especially those younger than 60 years old. And furthermore, this poorer rhythm outcome reflected the higher cardiac parasympathetic nerve activity during and measured by heart rate variability in women than in men after AF ablation. We proved the higher AF recurrence rate in women than in men after both de novo ablation and repeat ablation procedures, and this Cox regression analysis, worst rhythm outcome of a redo ablation was independently associated with women, non-proximal AFib, and extra PV triggers. So women and extra PV triggers are poor prognostic factors together after catheter ablation. However, antiarrhythmic drug response after post-AF ablation recurrence was significantly better in women than in men, and AAD response was also better in older patients over 60 years. These findings reflect their antiarrhythmic drug can suppress the extra PV triggers commonly found in women. So in conclusion, ladies and gentlemen, ventricular atrial mechanistic linkage contributes to the sex difference in the AF pathophysiology. LV diastolic function, ventricular adipose tissue, and atrial remodeling contribute to atrial myopathy, a higher risk of stroke, and higher recurrence rate after ablation. And female AF patients shows a poor rhythm outcome, and high risk of complication after ablation. Autonomic imbalance and extra PV triggers significantly affect AF recurrence after catheter ablation in women. Thank you very much for your attention.